We're meeting with her LA. And she thought it didn't start at 10:30. Thank you so much. I'm surprised you're not smart. Yep. Actually,
Okay. I think, hi, everyone. This is Terry Cole. Thank you all for joining us. We apologize. We were having a few technical difficulties, but it looks like we finally have everybody on and it should be working. I'm going to call the meeting to order. It is 10:26. And before we approve the minutes, I would just ask real quickly for those of you who are online, if you could enter your name into the chat box so that we know who you in what organization you're with, so that we know who all has joined us via the Zoom. And then we will go around the room here as soon as I guess we should do the minutes first, right? Let's call for the approval. So you all have seen the minutes for the May 2023 meeting. Do we have a motion for approval of those minutes? Anyone? So
I move to approve the minutes.
thank you. And do we have a second?
Second.
Thank you. Do we need to ask for, if anyone opposes the approval of the minutes, let us know. Otherwise, we will assume they are approved. And now we will go around the room just real quickly and take attendance of the MAC members who are in the room. Again, this is Terry Cole. We'll go this way.
Cirilla Blackman, Division of Mental Health and Addiction.
Zoe Fran, CEO and President of the Indiana Council.
Robin Shackelford, House District 98. Shelley Yoder, Senate District 40.
Senator Jean Lysing, representing 7 counties south and east of Indianapolis.
Rita Fleming, House District 71.
Ed Clear, House District 72.
Marty Wood, Insurance Institute of Indiana.
Cora Steinmetz, Indiana Medicaid.
Allison Taylor, Indiana Medicaid.
Former.
Okay, great. Perfect. Thank you very much. And thank you so much for your patience. We really appreciate you sticking through that with us. And thanks to those in the Zoom room. I will go ahead and caveat it to say that this is a bit of a network issue. So I would appreciate if you extend that patience through the rest of the meeting should we have additional technical difficulties. We've got a lot of presenters who are rapidly working to make sure their slides are prepared to share and sending to others if they need to. So thank you so much. Again, I'm Cora Steinmetz, and as of last Monday, I'm the director of our Indiana Medicaid program. To my right is, of course, Allison Taylor, who we are affectionately referring to currently as our Medicaid Director Emeritus. Allison is with us through September 5th, helping in an advisory capacity, which is just a fantastic opportunity for me as a new Medicaid director to have Allison here to keep my blood pressure low as we have technical difficulties, but do so much more and really ensure that we are doing our best to appropriately transfer a lot of knowledge. Allison, as I'm sure you know, was the Medicaid director here for 6 years and served as FSSA's general counsel for 2 years before that. So I would be remiss if I didn't acknowledge how grateful we are to Allison and everything she has done to support Hoosiers and our Medicaid program in the state. So thank you, Allison. Okay, just a few other housekeeping items. Our final meeting of the year will be Wednesday, November 29th at 10 a.m. in a hybrid format, well, tentatively. And then at that meeting, we'll also present our proposed 2024 dates. So be sure to grab your calendars for that meeting. Any other housekeeping items we need to cover before we get started? All right, let's dive into some of the substance. So from our FSSA Office of General Counsel, we have Amanda DeRoss, one of our staff attorneys, to give us an update on rules.
Sorry, I'm gonna try to share my screen and I'm afraid of breaking anything. So hopefully this works. Okay. So I made some slides this time for you guys. I know I talk really quickly, so hopefully putting the names and LSA numbers of rules up there will help anybody who wants to take notes. So I just have two rules to present today, LSA 23-366, which is our postpartum rule, and LSA 23-367, our electronic prescription signatures rule. I'll give you guys just a brief overview of the rules and where they're at in the promulgation process. And then if you have questions about the promulgation process, I can answer those. If you have substantive questions about the rules themselves, we have subject matter experts with OMPP here who can answer those. Where is it? There we go. Sorry about that. So the first rule is our postpartum rule. Again, that's LSA 23-366. This proposed rule amends 405 IAC 10-4-6C to extend the postpartum coverage under Medicaid from 60 days to 12 months. So for this rule, the public hearing was held on August 7th of 2023. The final rule was adopted by the Secretary on August 17th, and then it was submitted to the Office of Attorney General for review and approval just on August 21st. So the next step, once the Office of the Attorney General reviews and approves, the rule will be submitted to the Governor's office for review. Does anybody have any questions about that rule? Great. And the second rule is the electronic prescription signatures rule, which is LSA 23-367. This proposed rule amends 405 IAC 5-24-8 to clarify language to include electronic signatures. A public hearing was held just on August 21st of 2023 for this rule. And then the final rule will be submitted to the FSSA Secretary for final review and adoption probably today, August 23rd. If not, it'll be by the end of this week. And then once the Secretary reviews and approves the rule, it will be submitted to the Office of the Attorney General. Does anybody have questions about that one? If not, then that concludes my presentation of the rules. Thank you.
Great. Thank you, Amanda. All right, now we'll move into the next part of our agenda. So we have with us today Marty Wood from the Insurance Institute of Indiana, and virtually we are joined by our managed care entity equity partners, and they're going to provide an update on their health equity initiatives at each of the MCEs. This particular agenda item was set to be shared in May, but we ran out of time. So we're happy and appreciative that they're here to be with us today. So we see you all here in the room on the screen. So thanks so much for joining us, and I'll turn it over to Marty.
Thanks, Cora. I'm going to go ahead and share my screen now. Says host disabled participant screen sharing.
We can fix that.
Try it again.
Great. Here we go.
Okay. Thanks again. So for those who are unfamiliar, the Insurance Institute represents the interest of insurance companies doing business in Indiana, all lines of insurance. But it wasn't until 2020 that we became fully engaged in the healthcare space with becoming the manager of the Indiana Association of Health Plans. In addition to the commercial interest for the health insurance plans, we also represent them with the managed care and the managed care entities. And so today we have the opportunity, we've got health equity officers from the managed care entities. Those managed care entities are in Indiana, Anthem, CareSource, Managed Health Services, MHS, MDWise, and United Healthcare. So today we have from Anthem, Daryl Lockett, the Health Equity Director. From CareSource, Lakeisha Zachary, Director of Health Equity. From MHS, Dr. Shara Wisely, Vice President of Health Equity and Diversity Officer. From MDWise, Anya Carson, Health Equity Officer. And from United Healthcare, Janelle Kendall, Associate Director of, and I just it cut off, quality, sorry. So Without further ado, we'll move on to the presentation and I'll kick it off to Keisha.
Good morning, everybody. My name is Keisha Zachary. I am the Health Equity Director with CareSource. So our call to action today is just to provide some education and information to you all in regards to health equity and all the things that we're doing with our respective plans and with each other. So you may not know, but each of the MCEs, we all have goals and strategies to ensure that our members are receiving optimal care, regardless of factors that may contribute to disparities. So while our membership demographics may vary a bit, we collectively have similar processes to learn what the dynamics are of our membership, whether that's age, race, language preferences, ethnicity, geography, all of those things. Then we interpret that data, we identify the gaps that exist, and then we create targeted strategies that it may include our internal departments. So whether that's our case management, behavioral health, quality within our plans, as well as external partners. So we want to make sure that we're connecting with providers, that we're talking to schools, that we're talking to community partners as well, in order to make a strategy that benefits everyone. So we don't want to be a plan that we're making all of the decisions without consulting our consumer, whether that's our member or that's our provider, partners, employees as well. So we heavily rely on connecting with each other to discuss best practices, any barriers that we may have, also what are current trends that we're seeing within our state. Also, we want to make sure that we are being collaborative on projects like this. Luckily, we've been given the opportunity to connect with each other through our monthly Health Equity Officer Huddle meeting that the Office of Healthy Opportunities created for us, as well as our MCE Barrier Reduction Roundtable that we have each month. So during this process, we're constantly keeping in mind that in order to achieve health equity, we must include the voice of all, because not only do we have, again, goals within each of our companies, we want to make sure that we are ensuring equity for everyone, regardless of member assignment. So with that being said, I'm going to pass it over to Anya Carson with MDWise, and she's going to provide information about equity versus equality. Next slide, please.
Thank you, Keisha. Hi, everybody. On this slide here, I'll briefly reference the CDC definition of health equity. Really, in practice, this looks like everyone having a fair opportunity to have the best quality of life. And so this picture here on the slide is from an agency called the Robert Wood Johnson Foundation. And I believe it gives a great example of what it looks like to address health equity in the community. Really, when we're in discussions about equitable access and resources, each of us of the health equity staff works hard to ensure we are applying health equity and not equality. And so I'll turn your attention to the image for a visual explanation. I like to imagine that the individuals are in a bike race, racing towards the best quality of life. And in the top race, well, in the race on the top side, the individuals are given the same bike to finish the race. As you can see, the bikes provided, they don't exactly fit the individual that it's meant for. And therefore, not everyone is having that fair chance to bike and finish and reach their best quality of life. In fact, if everyone had that quote unquote fair chance to bike to finish the line, it actually would further disparities and gaps that we're seeing in the community. And so switching to the bottom side of the picture in this work, we really want to give what looks like health equity. And that really just means giving bikes that meet the needs of the individuals that it's intended for. You see that each bike in that bottom picture is uniquely tailored so that everyone has that fair chance to finish the race or reach their best quality of life. Some other examples in healthcare look like tailoring our outreach materials, making sure we have language services, a pay scale sliding fee, flexible scheduling, and accessible transportation. Really, this image is just a good reminder that as a community, we want to continue to remember that we're becoming more diverse. And as our role in healthcare, we must recognize that we have to tailor our efforts so it fits the needs of the community. And so with that, I'll pass it over to Daryl so he can highlight kind of the importance of addressing health equity.
Thank you so much, Anya. And with this next image, this is an analogy I'll use inspired by epidemiologist Dr. Kamara Phyllis Jones. So, let's say you walk past a lake and you find a dead fish. And we might ask ourselves, why did this fish die? What was wrong with it? Maybe it ate poorly. Maybe it didn't exercise, or maybe it smoked in it and that's why it died. And answer those questions, we dissect the fish. But what if we walk past the lake and we notice that half the fish in the lake are dying? Then our frame might shift. So we ask ourselves, what's wrong with the lake? We still probably think about the fish, but why did those particular fish die? And also the others? Well, maybe they have better genetics. Maybe they survived because they took better care of themselves, or they're eating well or avoiding harmful behavior. But even still, there are a lot of fish dying. So we probably need to test the lake to see what's poisoning half of the fish. And what if you realize that what's happening in the lake is also happening in lakes all across the state? I quote Desmond Tutu, who said, there comes a point where we need to stop just pulling people out of the river, and we need to go upstream and find out why they're falling into the river. So what affects one of us as a part of the state affects us all. And this image really shows that we must promote partnerships and collaborations that give greater support to programs to get people to work together to solve these social problems, which will ultimately bind our community together and deal with the problems that we face. So this extends beyond the traditional race-centered view of health equity to optimize health at the individual level for all, prioritizing efforts and investments focusing on health and healthcare, including addressing the health-related social needs and the social drivers of health to advance health equity and elevate members and communities that are socially or economically marginalized. But also this shows that no one entity is responsible for solving these issues alone. We believe that healthcare, government, community organizations, nonprofit, and other entities have a responsibility to address the social drivers of health and health disparities collectively. Next slide, please. But in that, we realize that, we have to remove the barriers that exist for members, and that's the right thing to do. And we build upon the mission of FSSA in that regard to compassionately serve our diverse community of Hoosiers by dismantling longstanding, persistent inequity through deliberate human service system improvement. And that centers on equity for all Hoosiers. So I thank FSSA for authoring that as our North Star and our marching orders, because we recognize that health inequities can be seen across a wide range of conditions, including hypertension, asthma, diabetes, cancer, mental health, and heart disease. And these conditions and narrowing these gaps become a priority because it's costly for Hoosiers. It's costly for the members with higher illnesses and death rates. It's costly for the state as a provider of these much needed resources. And it's costly from an opportunity cost standpoint to us as well. A team of actuaries that we work with at Anthem, but the team over at Deloitte also found that health inequities account for approximately $320 billion in annual healthcare spending across this country. And if that number goes unaddressed, it could rise to about 1 trillion by 2040. Here in Indiana, we see a direct impact because the rising cost of healthcare could go up almost to $3,000 annually. And that's not just for the Medicaid population, that's for commercial members as well, and all residents alike. The NIH has an estimate that here in Indiana, we're between about $1,000 and $1,500 per person as an increase due to health disparities. And nationwide, we're seeing about $451 billion on racial and ethnic health disparities. When we look at education-related disparities, that number rises to $978 billion and just under $3,000 a person here in the state of Indiana. So we realize that our state's ability to achieve is undermined when not enough people have access to the things that we need to succeed. And moving towards greater equity is achieved by improving the health of those who are economically and socially disadvantaged, but not by worsening the health of those in advantaged groups. Because when you address inequities for one population, you ultimately raise the health of all populations. And that's what we seek to do as we measure these outcomes on a monthly basis within our respective organizations, but the state is really holding us to task annually. Thank you so much, and I'll pass it on with the next slide.
Thank you so much, Daryl. So my name is Dr. Shara Wesley, and I have the honor of serving as Chief Health Equity and Diversity Officer at MHS. And as Daryl alluded, we are excited about our partnership with the state of Indiana and the Office of FSSA as we look to how we can really come together and have a collective impact in this space. For this portion of our presentation, I just want to highlight how we are synergistic with the Office of Healthy Opportunities, but then also about a new exciting endeavor that we've just completed this month. So this month, my colleagues and I individually submitted our first health equity plans. These health equity plans aim to capture each MCE's efforts related to health equity, as well as their progress or path forward towards achieving organizational goals. The overall goal of the plan was to really convey each organization's health equity journey and story, as well as highlight successes, opportunities for growth, support, collaboration, and for them to be able to get feedback from our state partners. In conjunction with this, overview of everyone's journey, each plan really had 3 foundational areas that were needed to be covered. So first was a member needs and barriers assessment. This needs assessment was a data-driven analysis of everyone's membership and ability for each organization to demonstrate their plan's population and gaps within their provider and member services. A second foundational element of the plans are also everyone identifying their health equity goals and programs, which laid out current and future goals, programs in relation to cultural and linguistically appropriate services or class standards and themes, and then a response to the disparities that may have been identified through their assessment. And last, there was a health equity outcomes and accountability section, which really looked to highlight how our goals and programs will be measured for years to come, for us to be able to evaluate and improve upon the interventions and programs that we're offering to the Medicaid population in Indiana. Next slide. Also, as Spirit, as a part of our collective impact, the health equity officers and my colleagues, Keisha and Dara, both referenced that we do have regular cadences where we interact with the Office of Healthy Opportunities. But here I just want to highlight how we first appreciate FSSA and their ability to pull us all together so that we can champion collaboration and focus on their strategic pillars, which they look to address at both the macro and micro level. And as an overview, those pillars include community engagement, which really looks at how we can have an increased presence in the state within our communities, understanding that health equity is local, being able to streamline our feedback processes between the state and ourselves, and then amongst ourselves around what we're doing within the health equity space, as well as being able to really have transparency on where there are opportunities or challenges that we can bring our collective thinking together to really leverage that intellectual power to really meet the needs of all Hoosiers. The second pillar within our strategic focus and collaboration is on policy and program design. So in real time, being able to have an understanding of gaps or in our service provision or gaps within the provision of Medicaid services in the state as it relates to health equity, and being able to communicate and address those policies in real time. The third pillar focuses on our workforce development, so where we're able to have conversations around retention of diverse staff members that is representative of the populations we serve, as well as being able to have transparency around opportunities where we can improve our relationship with within ourselves and our staff, but also with our state partners. And last, as a system, is the last strategic pillar is really centered on accountability. So having accountability does not have to be punitive. It's truly being able to have transparent conversations, being able to manage data effectively, having those continual feedback loops around effectiveness or inequitable or equitable practices, and being able to understand at a holistic level opportunities for us to be able to improve ourselves as leaders in the state, as well as being dynamic partners with the state. Now I'll turn it back over to Marty, who will set us on our next kind of course of our portion of this presentation. Marty?
Thanks, Dr. Wesley. So we've had a discussion about kind of baseline goals for the program and the interaction between the state and the MCEs. But we want to highlight a few of the existing programs that have been put into place that kind of are meant to meet those goals. And so I'm going to kick it back to Dr. Wesley.
Thank you so much. So with over 25 years of local experience, MHS really knows firsthand that individual and systemic SDOH factors contribute to health disparities. And these two diagrams that I'll walk you all through this morning, on the diagram on the net left, let's first talk about social determinants of health or social drivers of health, where really those non-medical factors that influence health or make health an easy or harder choice. These are the factors of where someone lives, work, worships, ages, and learns, and how forces within these factors shape the conditions of their daily life. Recent efforts to quantify the contributions of what do social drivers of health or what do social determinants of health really mean in terms of someone's quality of life or their ability to live a healthy life. There are different data points, but for here, what I really want to highlight is just the role in which social drivers of health. County health rankings, for instance, have said that overall 40% of your social determinants of health impact your quality of life, while actual clinical care or medical care only contribute to 20%. We know as health equity officers that health equity cannot be addressed without addressing social drivers of health. And we know that it varies across our state, but that the data does not lie, that many Hoosiers are battling with very complex, interconnected social drivers of health challenges, which make health a harder choice. On the right, I've outlined as our best practice that we would like to highlight today is our SDOH framework. When looking at our SDOH framework, our goal at MHS is to both identify and implement interventions based on data that we have on our membership, and then also proprietary data that we have on the general population within the state of Indiana. With that data, we are able to conduct data analysis to really hone in where the needs and even hotspot where there may be challenges that are coupled or layered or interconnected, and to create scores around barriers. So being able to say certain communities may have a higher score, so to speak, around, which means that those populations have increased barrier accesses as it relates to social drivers of health. In addition, our framework focuses on home and community resources and how we can have local delivery and support of those resources. This SDOH framework does not sit in isolation, but it is overlaid with our health equity model and as well as our rural health framework. It's foundational to our effectiveness in really being able to effectively identify and connect members with housing, utilities, support, transportation, food assistance, employment, and other resources, both in our urban and rural communities. I love frameworks, but I do want the group to understand that this framework is essential because it really helps us be able to systematically organize ourselves around our policies and procedures. But how does this show up on a day-to-day basis between MHS and our supportive members? At MHS, we have something what we call a no wrong door approach. This approach is centered in that anytime a member interacts with the MHS staff person, that initial SDOH navigation support can be offered. We want to be sure that if we have a member on the phone with us or in person out in the community, and that they identify SDOH need, that we immediately have a pathway to be able to navigate that member into one, being connected to community-based resources, or connecting them to very specific MHS SDOH programs. We can connect these members not just out in community, but even through our care coordination and case management models. We know that the goal is to remove barriers, to serve the first thing first. The understanding that oftentimes before we can even have a conversation around medical or clinical needs, that we first must address SDOH needs. I'll stop here and then turn it over to my colleague, Anya Carson.
Thank you, Dr. Wesley. Alrighty, at MDWise, we really use our Back on Track events to help bring provider and community resources to family in Indiana's. Really, our goal here is with these events is to get our families caught up from missing appointments during the COVID-19 pandemic. And so families, community partners, and provider groups are all invited. And at a typical event, you will find a provider group with the standard health checkups, vaccines. We also provide food, sometimes food boxes to take home. And then we typically coordinate a fun family activity, some giveaways, and some gift cards. Some of our partners our team collaborates with includes the Department of Health, local health departments, any health systems or provider offices, again, any local community organizations. And it's really open to all of the community members. With the health equity lens, we prioritize where the need is geographically when it comes to access. And so we are regularly performing a SWOT analysis to assess how to widen our impact. In addition, we are also wanting to discover, like Dr. Wesley, what social needs or resources are needed during the time we host these events. So just to give you some examples of the data we review, we will filter health outcomes by region, racial and ethnic groups, so we know which populations and areas have that unmet need. Specifically, we'll look into dental utilization and lead screening among our children under 2. Some of the key highlights we're seeing just from looking at social needs really with our members is that they need support right now with food, jobs, housing, and addressing legal concerns. And so one of the ways we leverage that information is making sure at a Back on Track health and wellness event, we'll have community partners that really focus on areas and that can speak to our members about these matters. On our slide here is the impact so far, but we really anticipate this number to grow as we move through the calendar year and providing that comprehensive and those data-driven efforts. I will move down to some of the lessons learned through this effort because we really want to be mindful of how we're outreaching and marketing to our members for these events. In the past, we've just used like snail mail, postcards, but we really have expanded to use text reminders, yard signs, social media posts, and thinking about kind of the diversity of our membership, we also look into kind of those language options, making sure we have an interpreter. On the slide here is just an example of a flyer in Spanish of how we try to accommodate those different language barriers. One of the other kind of main lessons learned that we like to leverage is our use in collaboration with our trusted partners in the community. We can't do this work without those agencies in the community that know their neighbors. And so throughout this effort, we've really established some amazing relationships here with those agencies listed on the slide. And again, we look forward to kind of expanding this impact as we move on. And with that, I will pass it to Keisha.
Thank you, Anya. Much like Dr. Wesley and Anya spoke on, there are so many things that we noticed as it relates to SDOH needs. For example, if a member is concerned about their next meal, if they're concerned about safety in their neighborhood, things of that nature, then getting a prescription filled may be low on the priority list. So one of the things that we noticed at CareSource with our membership is the disparities that exist in regards to the chronic disease of asthma. So we noticed that there is a larger incident of asthma in African-American families, in Black and African-American families, not just children, but adults as well. So we created the Asthma Collaborative Project with the focus being Black members with asthma. And we had to look at the counties because one of the things with equity, which is a good problem, but also can be stressful at times, is that we want to change everything everywhere immediately. And that just doesn't happen. So we had to be targeted to see, okay, exactly where is our population that's experiencing these areas? Where are they located geographically, and what can we do? Who can we partner with in those spaces to have an impact on those outcomes? So we chose to look at our top 5 counties, which were Marion County, of course, that's Indy Central. We have Lake, which is our northwest area, Allen, northeast, Vanderburgh, south, and then we have Tippecanoe around like the Purdue, West Lafayette area. So what we did was we looked at that to see, okay, what are the issues? And then we each probably have population health dashboards to where we can see certain things about our membership in those areas. We utilize our claims system to look at not only who have the diagnosis of asthma, but are there any emergency room visits that correlate with that? So how do we address this problem? Because asthma, while it is a chronic disease, it can be treated. It can be things that we can do to prevent attacks or going to the hospital. So again, the purpose of the project is to reduce those health disparities through evidence-based strategies, person-centered approach. And like Anya stated, we can't do this work by ourselves. So connecting with partners, connecting with those families. One of the things that we also do, because there are kids, we know where kids are or where they should be during the day, is at school. So we utilize our contacts within school systems. We work with not only the districts, but we also look at the school nurses, because sometimes those are staffed by local hospitals or provider networks. So we wanted to make sure that we connected with all of those pieces, those moving parts. And then while it is something that we just initiated this year, we do have an early impact already. So the member outreach that we have conducted to assess member needs, not only are we looking at asthma, but we're also looking at those social drivers of health. Just wondering, like, do they have food? Do they have transportation? Are there other needs within the household that we may be able to connect them? We have a Find Help resource that we share with our members that can assist with resources within the community. One of the things that we like to say is that we do not have to be all things to everyone, but we want to be aware of what exists in the community so we can connect our members to resources that are within their neighborhood. So again, the early impact is April is Asthma Awareness Month. So we were sure to include an editorial in our member newsletter for Medicaid to talk about triggers, to talk about things that you can do to prevent asthma attacks. Also local resources within their community for asthma support. We also did a provider notification through our provider engagement team to just look at, okay, who are our pediatricians, who are the family doctors that are treating our members in these 5 counties. So we did targeted outreach to them as well. And then we also, of course, did school outreach with our school-based administrator that we have as a staff person here. And then in the summer, we worked with Covering Kids and Families to have a poster presentation of our asthma collaborative project at the Indiana School Health Network Conference. So again, like Anya mentioned, we can't do this work by ourselves. So we have partnered with Indiana Joint Asthma Coalition, started out in this space, but now that relationship has blossomed. So now we have quarterly touch points with their Health Connections of Indiana. So the NJAC sits under that. And so we are looking to work with them on other opportunities as well, not only asthma, but there's other things that we can work on, and also the Indiana Association of School Nurses. So again, we are looking forward to reviewing at the end of the year when we have projects. We look at it to say, okay, what worked, what did not work, what can we shift, what can we pivot, how can we pivot, and then also get member feedback that have participated in the project so that we can make efforts to streamline processes if needed, and also to be better. Whatever that looks like, we take that data, we use it, and to make change so that we can be more effective in closing this gap related to asthma. And so with that, I will pass it over to Daryl, who will talk about maternal and child health.
Thank you so much, Keisha. And we laughed when we sort of, delegated who was going to talk about what, to have the lone gentleman talk about maternal and child health. But I stand committed to the issue alongside Anthem, but alongside many men, because this is an integral piece of, just a crisis that we're facing in society. But ultimately, our goal is to make meaningful, sustainable, and systemic change that will lead to a state where the impact of racism or socioeconomic status and access to healthcare is no longer a predictor of stillbirth. Preterm birth are the second largest contributor to infant mortality. Indiana loses on average about 502 babies a year due to stillbirth. And based on the most recent 5-year average, that stillbirth rate in Indiana, it's 6 deaths per every 1,000 live births. But Black residents in the state are seeing about 9 deaths per every 1,000. Hispanics are seeing 5 babies lost for every 1,000. And our white residents here in the state of Indiana are seeing 6 babies lost per every 1,000 births. The preterm rate for Black pregnancies in the United States is about 50% higher. And that's proving to us that there are inequities in this space that we need to address. Black women are 3 times more likely to have maternal death. We've had some very touching ones that have happened in our state. If you've ever gone to lunch or even walked the hallways with Representative Summers, I'm sure you've heard about this issue and just how critical and how important it is. So research from the American College of Obstetrics and Gynecology shows that there are several contributing factors towards the health disparities that we're seeing around stillbirth. Parents of color are more exposed to conditions like gestational diabetes and preeclampsia. We see that access to healthcare can have an early impact on diagnosis of conditions and treatment. There's socioeconomic barriers that you've heard time and time again throughout this presentation. But one thing I also want to point out that is, sometimes something we don't consider, but education is not seen to be a determining factor with the outcomes that we're seeing around maternal and child health. A college-educated Black woman is still more likely to lose her baby than a high school educated white woman. So there's some things in this that we are really trying to understand. But this solution that we've launched here in the state of Indiana puts a lot of that power, a lot of that influence for change in the hands of members, in the hands of Hoosiers themselves. It's a partnership with a wonderful organization called Count the Kicks. It's an evidence-based stillborn prevention and awareness program that teaches expected parents the methods and the importance of tracking fetal movement. Research has shown that tracking fetal movement is the best non-invasive way. So often we're thinking just on the clinical approaches, but there are a lot of technological approaches. When we go to the internet for so many things, how can we bring the internet to members so that they can be a leading advocate for themselves in their health outcomes as well? But, we've seen that babies can be saved when expectant parents are educated to really know about normal movement patterns starting at 28 weeks and speak up if they notice a change. You've heard it here before. It's going to be more than just, the MCEs, more than just the providers, more than just government or community-based organizations. We want to empower Hoosiers to speak up for themselves. And what we're doing is really trying to replicate this 39% stillbirth rate reduction that has been seen in the state of Iowa, where Count the Kicks was birthed and launched. And as we brought this here to Indiana, I'm happy to report that 2 Hoosier babies have already been saved in the last year, where Anthem and Count the Kicks has partnered to get this app in the hands of so many users. 84% of the users have stated that regular tracking was associated with feelings of bonding with their yet born child, and 77% of the app users said that they felt less anxious. And it's these things that don't seem to be the traditional approaches that oftentimes will unearth and unlock the learnings and the takeaways, because this program has engaged stakeholders in a meaningful way at all levels of practice. It's, empowered and educated members of our plan, but so many other plans, because, we're putting this out statewide to have these conversations with their providers to really grow in that relationship. And it's been validated by third-party research. And I think that's something that's key, that all of my colleagues in this work are truly doing. It's not just to say, hey, we believe in it, but to find a research entity or another academic institution that can say, yes, you're making a difference. We've partnered with Indiana Minority Health Coalition around Count the Kicks, but we recognize that to improve these outcomes, we have to grow in our understanding of prevention strategies to break down systemic maternal and reproductive healthcare barriers and biases, and most importantly, actively recruit and connect with community allies to walk alongside our organization, our members, and Hoosiers alike. So, I thank you just for the opportunity to present today, but we are very excited about the outcomes we've seen so far in saving 2 babies here in the state, and look forward to better days to save even more Hoosiers as we empower members and non-members alike to really be an advocate for themselves around the maternal and child health space. So I'm going to turn it over now to another colleague in this work, Janelle Kendall with United Healthcare. Thank you.
Thanks so much, Daryl. And Janelle, if I could just briefly interrupt. I think we've got a couple more slides here from our MCE partners, but I also just want to do a quick time check because I know I think some may have questions. So I want to be sure we leave plenty of time for that. So maybe if we can wrap up in the next like 3 to 5 minutes, that would be great.
Yes, absolutely. And are you able to hear me all right?
We hear you great.
Okay, just very quickly before I start, and I will keep it brief, I wanted to announce that as of August 14th, Lori Weinzaffel is the United Healthcare Health Equity Officer. Just wanted to put that information out and let everyone know how thrilled we are to have Lori in that role. So I'm going to be talking about what we are doing in the diabetes realm. All of the managed care entities rely on data in determining where disparities exist. We have relied on data to tell us diabetes and diabetes-related complications are more prevalent in the Black, Indigenous, Asian, Hispanic communities, and really for all people of non-white racial and ethnic groups. United Healthcare is finalizing, working with a vendor who's going to offer some additional care opportunities, technological opportunities for our diabetic members, including those members in these particularly vulnerable populations, to help them get a handle on their diabetes, recognize where barriers may be for them getting the best care that's available. And we'll continue to look at data, figure out where those members are, and help them in every way possible. And I just have one more slide. And as I mentioned, data is really key in helping us to determine all things about health equity and disparities. I know that all of my MCE partners are always developing plans to secure additional data to learn about our populations. We have at least one managed care entity that offers a provider incentive for providers to bill with Z codes, which are codes that tell us about a member's social determinant needs or social driver's needs. We, I believe Dr. Wesley already mentioned that we've completed our health equity strategy plans. All of the managed care entities are doing in-house training. So all staff that are interacting with members and providers are going to be well informed about health equity, disparity, social drivers of health. And we're just going to keep continuing the journey. Over time, our efforts to address health equity will be larger and more fine-tuned, and hopefully do great things for our Medicaid enrollees. And then hopefully I've left enough time for some questions.
Wonderful. Thank you for that presentation. I'll open it up to MAC members that might have questions. Representative Shackelford.
Thank you. Well, first, I just want to congratulate the MCEs on getting these officers, making out a plan, and actually addressing this issue that has been a concern for years coming. So I'm excited to see that and see your information. One, I want to know, are we going to get a copy of the plans and their progress? I would love to see that detailed information. Two, I have for a long time been trying to get healthcare providers and healthcare professionals trained in cultural competency, also implicit bias. So does the work that you're doing, are you going to have any type of recommendations or requirements that the providers that you work with actually receive this training? And then lastly, are the MCEs, is their reimbursement tied to their progress in this area? Is OMPP, do we have any reimbursement indicator that's going to be tied to what they get for reimbursement? Thank you.
I think as a starting point, we're happy to provide additional information around the plans and progress. Are there any MCE partners who want to speak particularly on the provider question?
I will. Through Anthem Indiana Medicaid Academy, we do a lot of education around cultural competency, such as culture and trauma, empowering therapists to work with LGBTQ youth and family, to understand trauma-informed care and the systems, but understanding just the resilience and also the implicit bias that goes in there. So we provide that training available. We have a portal, My Diverse Provider, that any of our providers that are signed on with us, but also widely providers that aren't affiliated with Anthem can tap into as well to meet these needs and have these conversations within their practices and to better serve Hoosiers alike.
And if I could add to that briefly, I think each of the MCEs probably have different plans and strategies as it relates to provider education surrounding cultural competency, implicit bias. Currently, we have a cultural intelligence series that we're doing in a partnership with Aspire with Dr. Gina Forrest. It's a monthly webinar that's not only for our providers, but also employees. And then we also have other partnerships where we conduct racial informed trauma training and things of that nature. Again, not only for partners, but employees too, because we want to make sure that our employees are versed and knowledgeable so that we're not doing harm when we're engaging members as well.
And yes, Keisha, United Healthcare also provides opportunities for education for our providers, including opportunity for them to get CEU credits.
I would say everyone provides training. The only thing I would add is that also as a part of our contract with the state, everyone should have a provider advisory council. Those councils do different things, but one of the functions at MHS that council does is help work with us on our health equity strategy, as well as be able to collaborate on issues that may arise that need a health equity review.
Great. Those all sound fantastic. Thank you.
Representative Shackelford, I just want to address quickly your question around reimbursement. And today, I don't believe reimbursement is specifically tied to this. However, it's certainly we can look at in the future with our pay for outcomes. And additionally, as we spin up our Pathways program, the Managed Long-Term Services and Supports program, MCEs will report this information as part of their quality data that is required to be reported to OMPP. So I think we have a lot of opportunity in the future in that regard.
Okay, thank you. Yes, I would love to see a reimbursement criteria added.
We'd be happy to partner with you on that.
Okay,
Senator Lysing?
Yeah. In regard to the fact that the maternal mortality and morbidity report shows that addiction seems to be a prevailing cause of problems, have the managed care organizations looked at that specifically and addressed that issue as they're trying to help people have better outcomes?
Great question. Any MCE partners that want to speak to that? I know on the Anthem front, we heard a little bit about this as well.
I would say yes. And so the Indiana Pregnancy Promise Program collaborates with all of the MCEs when looking at maternal health, child health outcomes, and it's in a relation to substance abuse. I think in the state of Indiana, we've also participated in the doula work groups that have recently came up in the state, where we're looking at the role of community-based doula support and how it could help mitigate barriers around maternal and infant health challenges that we see within the state. So those are two ways where I could say, at least as a collective group, that we are collaborating with state entities around the maternal and child health crisis that we're seeing in the state of Indiana, and then the overlay of having the comorbidity of both substance abuse challenges.
And I'll add to Dr. Wesley on that. One of the things that is interesting to note, the maternal mortality indicators actually span out 12 months postpartum. So, so much of that slide talked about stillbirth, but when we begin to think about 12 months postpartum, we're introducing many of the other social determinants and social drivers of health, many of the other supports that we presently have, each of the MCEs in terms of supporting substance use disorder, because those factors and forces in the environments that birthing persons are returning to and children are spending their first year of life are also influenced by many of these externalities. So we're addressing those in supportive programs as well.
Great, thank you. And Allison raised a great suggestion, which we could present on the Indiana Pregnancy Promise work in a subsequent meeting if there's ongoing interest in that, and how it sort of fits into the My Healthy Baby umbrella with across other state agency programs as well. Representative Fleming.
Thank you very much. Briefly, again, talking about maternal health and ultimately infant health, we know that one of the risk factors is close spacing of pregnancies, and that one of the places we fail is offering contraception to women where they are, particularly in postpartum units and the opportunities through the emergency room and places like that. What can we do? What can you do as healthcare providers and representatives, and we do as legislators, to make sure Senator Yoder had a good start with her long-acting contraceptives, but we need to do a lot more. How can we do that, particularly in the postpartum area? The best I could give a woman who wanted long-acting contraception before she left the hospital was a 3-month depot shot, and that is not good enough.
So I think for us, one of the things that we're doing is more work around women's health education as a whole, and that includes that interconception piece. Outside of my role at CareSource, I'm also a doula. So that, and Dr. Wright is who I sit under. She is a practicing, prior to coming to CareSource, practicing OBGYN. So that is something that we are definitely looking at as a priority, is to focus on that interconception education, because we will be able to discuss those types of things as it relates to pregnancy spacing. And not along those lines, we also just want to make sure that we are partnering with agencies across the state that support, that provide that prenatal case management program, whether that's Indianapolis, whether that's Healthy Start or a Healthy Families or a Nurse Family Partnership. We just want to make sure that we are aligning with partners, and again, those that are touching our birthing persons, and then that community, just to make sure they're aware of that spacing and also resources that are available to them. Because we know that knowledge is power, and so we just want to make sure that we're providing the right education so that we can support our members as it relates to this particular issue.
Those are very good initiatives, and they're great for the person who has had care or is willing to seek care. But too often we have women come to the hospital with no prenatal care whatsoever and leave with nothing. And that's unacceptable. And that's where we get the whole cascade of children who are not cared for properly, DCS involvement at a great cost to the state.
Absolutely. Thanks for those comments. I think we could potentially wrap that into a future conversation with the Pregnancy Promise, and maybe provide an update also on some of the investment around the Hoosiers Family First Fund, which made some strides in this space, as well as what the Medicaid team is doing to implement the pharmacist prescribed contraception bill and the state plan amendment in that space. Okay, thanks for those comments. I think Senator Bro and then Senator Yoder.
Cora, can you tell me if I can't remember? Hi, Allison. I'm glad to see this is your last meeting.
It is.
This
I know.
is
I
it?
just keep coming back. This is actually the last.
Well, no, I think you said you were gonna, no, she's running it, but yeah, well, it's good to see you. It's good to see you, Allison, and you will be missed. But anyway, Cora, can you tell me again, does Medicaid reimburse for a long-acting reversible contraceptive implant?
Yes, we do.
Okay, thank you.
Great. Okay, Senator Yoder and then Representative Clear.
Thank you so much. My question is maybe for our managed care entities and wanting just reassurance as we are hearing more on a national level and definitely in the legislature, some of these culture wars around talking about issues of equity. Do you feel that you have the support from the from your leadership in these entities to continue doing this work and to continue doing the work that is necessary in order to address these significant disparities in outcomes?
Good question.
Hi, everybody. It's Anya from MDWise. I'm okay to chime in here and fully say, yes, I do feel supported. And one way that it's coming out is our accreditation partners with CMS and NCQA. There are elements and standards that health plans have to abide by to meet health equity and multicultural distinction. And so the support is definitely there one way or another.
And I would say on top of that, I think it has been embraced by the state, understanding the significance and importance that we maintain class standard accreditation. We maintain NCQA accreditation. We're pursuing NCQA Health Equity Plus accreditation now to really go over and beyond forging the community partnerships. And I think that understanding and realization is coming from the top down within our respective organizations. But we're seeing that within FSSA, the Office of Healthy Opportunities, the previous Chief Health Equity Officer, Dr. Bianca Merritt. We're welcoming Dr. Corey Carey in a few days to really embrace that and sort of provide that support. The state has done a wonderful job in creating a spirit of more camaraderie than competition amongst the MCEs. We have monthly calls to address disparities, monthly calls to talk about common challenges that we're facing. And it's, sort of created this, I would say it's a wonderful, I don't even know the best adjective. It's a wonderful working environment amongst people who are committed to improving the health outcomes from the state of Indiana. And we see that both in our organizations and, coming from the state as well.
And I would definitely have to agree with Daryl. What he didn't mention is that we're going to go out to dinner to celebrate that we did this. Because we definitely feel supported amongst each other with the Office of Healthy Opportunities and also with our leadership, just from a CareSource lens. This was the first time that health equity was required under this particular Medicaid contract, but CareSource, we have our life services department, which focuses on social determinants of health and connecting our members with those resources. We've had that program since 2017. So we've already been doing the work of equity, and it's definitely something that we are passionate about, our leadership is passionate about, and we're just now grateful that there's so much emphasis on it. It can be a lot of work, but with having the support internally, externally, and with peers, because it's not a competition, it feels really, really good to have so much support behind us to do this work.
The only thing I would like to add is that I want the audience to not take that for granted. So we all work together here in the state of Indiana, but by nature of being a part of this work, we have colleagues and peers that are servicing other Medicaid programs in other states. And those states are not implementing the intentionality that we're seeing here in Indiana. And so with the state really stepping up and requiring things, it creates room for this collaboration. And we're realizing that this governance is not something that you're seeing nationally across the implementation of Medicaid in other states. And that by not having that intentionality, health equity becomes optional or viewed as extra credit, while in Indiana with the new requirements and the space that is being created for this work, that it is no longer considered extra credit in Indiana. It's considered best practice, and it's being leveraged and appreciated as such. So it's been a very refreshing environment to be a part of and to be on the front end of this innovation. But I just don't want the audience to take for granted why that makes it special here in the state of Indiana.
Thank you. Representative Clear.
Thank you, Director Steinmetz. And thanks to Mr. Wood and his members for their presentation and for the work they're doing to improve health equity and reduce disproportionality. I'd like to ask about enrollment, and maybe this will be a segue into the next part of the meeting as well. Obviously, the work that your members do, Mr. Wood, is within existing enrollment. So what is being done to increase health equity and reduce disproportionality through enrollment? And then again, looking at the next part of the meeting, are we tracking disproportionality in the disenrollments for procedural reasons? I think that's something we should be tracking if we're not.
Great, thank you for that question. If it's okay with our MCE partners, maybe we'll move into the unwind update, and if they're able to stick around to answer any specific questions as it relates to this. Okay, we'll do that just in the interest of time. So thank you so much, Marty, and to our MCE partners. So next up, we have Nanis Spinner, who is our Director of Eligibility, and with her is our FSSA Director of Communications and Media, Michelle Holtkamp. So they're going to provide an update on return to normal operations, or PHE unwind, or Medicaid eligibility review actions. It goes by many names, but I think we're all pretty familiar with it. So Nanis, we will kick it over to you.
Thank you, Cora. So I am going to start. Hopefully you can hear me. I'm going to start and go over some of the outcomes we've seen, and then I'll pass it to Michelle, and she can go over the outreach that we're doing.
Yeah, a little hard to hear you.
Is that any better? Hopefully. Okay. I usually don't have any problem being heard, but yes. So I said, I'm going to go over some of the outcomes we've been seeing, and then I'll pass it to Michelle to go over the outreach efforts we're doing. And I'm actually going to do a live demonstration, but I didn't want to not have a slide deck for people who are viewing this later. So I'm going to walk you through how to get to where I'm going to go. So you will go to in.gov/Medicaid. And then you will see how a return to normal will impact some Indiana Medicaid members. So you click on that. Oh, excuse me. And that's going to take you to our main page. And if you scroll down just a little bit, you will see that we have three kind of hot buttons for things that we know people are going to want to go to. One of those is an option to click to view the CMS reports and dashboards. And then we're going to go over July 2023. Because of our internet issues, I kind of preloaded these, so I'm hoping that you'll still be able to see my screen. Okay, there we go. So again, we go to Welcome to Indiana Medicaid. You will click on how return to normal will impact some Indiana Medicaid members. That's going to bring up this page right here. And let me make sure I can do this. I've got a little slider here I might have to move. Once you come here, if you click on the CMS reports and dashboards, that will bring you to a page that looks like this. This has all of our reports to CMS. So the first item up here, these are kind of our baseline reports that we did before we started any of the work and kind of explain what our plan was. We've got our monthly reports, including a guide on how to read them. These are the actual reports that we submit to CMS every month. And then we've also developed dashboards to help explain a little bit more about the data and what results we're seeing. And one other thing that I wanted to point out, last time we met and had this as an actual MAC agenda item, we were talking about April, which was our first month that we had any results from. Since then, CMS has released all state data. And so that lets us have kind of a picture of where we are in comparison to other states, which I think is helpful for us. And we've put a link here to the CMS data reporting. If you click here, you will get to this site from CMS. And what you want to select here is the monthly data reports. When you select that, and anyone who needs a breadcrumb trail to find this later, I'm happy to provide that. There is an Excel version. I've also got that preloaded because I wasn't sure about our internet. And this is a comparison of all states that were reporting in April. So as you'll see, when we bring up July, we've had some definite improvement since April, but just looking at the April data, the share that were renewed, so people who went through a successful renewal as of the last day of the reporting month, the national average was 45.53%, and we were at 41.28%. So we weren't quite up to the national average, but not too far off. And then the other one that I think everyone has been interested in, we can also look at, I believe our ex parte rates are here. Here we go. So the national average for ex parte, which is an auto renewal where the person doesn't have to take any action, was 25.41%. Indiana was at 25.84%. So we did pretty well on that one. And then on the procedural disenrollments, the national average for April was 25.59%, and we were at 29.74%. So again, a little higher than the national average, but wanted you to be able to see the comparison now that we have that for April. CMS will continue releasing these statistics each month. May will be the next one, and we should have that one in a week or two at the end of this month.
Now the fact that we're 29.7 for procedural disenrollment, that's not good, is it? We're higher than the national.
It was a bit higher than the national average for April, but we're going to look at July, and I think you'll see a marked difference there.
Okay.
Let me go back here. So when you're on this page, if you select July 2023, that's going to bring you to our dashboard. As of right now, it's a static dashboard, but we do have a lot of information included here. So the first page is going to show total enrollment over time. And so it kind of starts with before the public health emergency, where again, we were at that 1.4 million, shows all the growth during the public health emergency. And you can see that July is actually the first month that we saw actual decreases in enrollment, because there's a little bit of a delayed action on that, because when we tell someone that they're going to lose their Medicaid, it's actually in advance of the action being taken so that they can avoid it if they turn their things in, or they at least have advance notice and it's not a surprise when they go to the doctor or the pharmacy. So for July, we had 149,331 renewals that were due. We successfully renewed 52% of those, and I can't toggle back and forth because it would make us all seasick. But for our April statistic, we were at 41.28% that were successfully renewed. So we increased quite a bit there. And then our procedural disenrollments, again, in April, that was 29.74%. For July, it was 19%. So we had quite a bit of improvement there as well. And you can see over here, we've also provided a breakdown of those procedural disenrollments. So one thing to note is for July, and we have this for other months too, when you look at the other dashboards, 24% of these members did have other coverage. So they aren't individuals that had nothing to turn to. So they may have had employer-sponsored coverage, they may have had Medicare or other coverage. Medicaid was not their only source of health coverage. 2% of our procedural disenrollments were people who turned something in, but not enough for us to be able to see that they were eligible. And this also includes some members who were deceased, incarcerated. We knew that they no longer lived in Indiana, or they voluntarily withdrew from the program. 6% of our procedural disenrollments, the last thing we knew about them showed that they were not eligible, but we sent them the form to say, can you give us some new information that shows you should keep your coverage? They did not respond to that. And then 11% of these were individuals that just did not respond at all.
You said the last thing we knew about them. What is that?
So we have someone, and the last thing we knew about this person was that they looked like they were over income, but we didn't close them without giving them the opportunity to say, what you have isn't right. So if someone would have returned, no, I don't have that job anymore, they could have kept their coverage. So these individuals looked like they were ineligible. We gave them the opportunity to give us new information, and we did not get any new information on them.
And the 2% that were ineligible, that tried but failed because they didn't have enough paperwork, what happens to that group? And what number, when we say 2%, can you give me a number that
I
equates
do
to?
not have the number. I don't know if anyone can do.
All right,
the
I can
back
figure
of
it
the
out.
napkin.
I can figure it out. But what happens to that group that tried?
Yes. So the individuals who voluntarily withdrew, passed away, or no longer live in Indiana, they are not eligible for Medicaid. For individuals who maybe they turned in something that we needed, but not everything, and we would have asked them to clarify, they would qualify for that 90-day reconsideration period.
Okay.
So if we asked them to provide a particular pay stub for one day, and for example, and they didn't get it in by the deadline, they would have 90 days to turn that in and potentially regain their coverage.
Okay. So do they still have coverage during the time that they're getting you that pay stub?
These individuals do not. If we gave them the first opportunity and they didn't return it. The individuals, you can see there that we had 26% at the end of July who were still in process. Those individuals do still keep their coverage until we make that final determination. So the 2%, we made the final determination, did several outreaches to them, were not able to see that they were eligible because something was missing. And so they have the 90 days to turn it in.
But they're still eligible for retroactive coverage.
Unless they are HIP.
Unless they are HIP 2.0. And I want to get back to that later.
Yes, and they would be eligible for presumptive eligibility as well if they had an emergency. And going to the next slide, we do have some demographic information here. So what we did is we showed, this is for our procedural disenrollments. We showed the disenrollments by program, by age group, by ethnicity, and by race. And we also wanted to show for context what our total percentages are for the whole program. So for example, if you look at the disenrollments by program, HIP was 46% of the disenrollments, and for our total population, HIP is about 36% of the population. So you can see that if we have any disproportional impact, it's that our non-disabled adults are the ones who are losing their coverage more so than other groups. And then when you look at the age group, children who are under age 19, the disenrollments were about 29%, and they are about 40% of our total enrollment. So just for some comparisons there. And we also have the ethnicity and race. We have not seen anything, it varies a little each month, but we haven't seen anything that's very out of line with our total population there, but definitely something we continue to monitor. Okay.
Can I ask, since you've taken a breathing break, you said that population less than 19, 29% of them have been disenrolled, and that represents, that less than 19 represents 40% of the, did I get that right?
So the Medicaid program as a whole, 40% of our members are under age 19.
And 29% of them are disenrolled. 29%
of that month. So the disenrollments that we had for July, 29% of that, which is a much smaller number, were under age 19.
Okay, but that's almost half of those that are. Am I reading that correctly?
I think what it shows, Senator Bro, is that although children or those under 19 represent 40% of our Medicaid program, they're being disenrolled at a rate that is less than how they are represented in our overall Medicaid population. Okay. Of our disenrollments that occurred in July, 29% of them were under 19, as opposed to if you just looked at our population overall, it would be a bigger percentage.
That still seems relatively high though, given that that age group is the group that needs the insurance. I mean, they're very vulnerable for healthcare needs, and 29% out of a total population of 40% still seems to be relatively high to me.
Well, we definitely would want to see, those numbers as low as possible and are doing everything possible to make that happen. One additional thing we've started doing in all of our outreach, which I don't want to steal Michelle's thunder, is our messages the entire time have been update your contact information, watch your mail, and respond when we send you something. We've added a fourth item, which is parents, if you are not eligible, your children may still be eligible. So please return your paperwork, because kids can keep their coverage because the income limits are higher, even if the parents may not.
Yeah, okay.
I'll just keep going here. At the next page that we have, this may be a little hard to see, but when you get into it, of course, you'll be able to see it. We've got each county, and of the procedural disenrollments, how many happened in each county. This is really helpful for advocates who maybe want to target their outreach or who operate only in certain areas of the state. And then for each month, you'll see the outreach efforts that we did. This is for July. So it shows our advanced outreach, the postcard and the 211 outbound call. Those happened before we started doing any of the renewal processes. And then we have our specific outreach for July, which was the warning letter, the renewal packet itself. We also did text messages, and DFR did outbound calls and emails. And I will pass to Michelle because I think she's going to take it from there.
Good morning, everyone. Thank you. I will just give a brief update on our ongoing outreach and communication efforts. I did want to note that even though we are many months into these efforts, our work in outreach is as strong as ever. We have not let off the gas any since day one or even pre-day one. Still in the hopes of reaching members who have yet to be redetermined or who are in that 90-day grace period, or if needed, give them information to help them come back onto coverage or find new coverage if they have lost coverage. So to capture some of the work that we've been doing since day one, we continue working closely with the hospitals and the managed care entities and nursing facilities so they can contact their patients and clients when they are up for redetermination, remind them, in some cases, even walk them through the process. We've connected with food banks across Indiana, national and local pharmacists, the mental health clinics, school officials, community health organizations, and the advocacy groups. So we're really trying to give them all the information, resources they need to help in the communities. We show them the resources we have available that we'll send them for free and ask them what else they need that would help their clients. I remember specifically from one stakeholder meeting, a case manager shared how they were going to use the resources and show informational videos to their clients while they're in the waiting room and then sit alongside them to make sure that they went through the redetermination process. Additionally, we meet weekly, biweekly, or monthly with the Hospital Association covering kids and families, the Minority Health Coalition, Hoosier Action, the Indiana Justice Project, the Indiana Primary Healthcare Association also. These relationships are really proving critical for us. We're getting real-time feedback from folks who are working on the ground in communities, and then we're able to adjust our work and answer questions and help. These organizations are also really important to us in doing outreach as well. We've put our materials in Work One centers across the state at the community colleges. We've given it to the emergency responders and the providers who are involved in child welfare cases. The local health departments have been engaged since the beginning. And then recently we circled back to them to see what they needed when they are working with families who are getting their kiddos their back to school vaccinations. First Steps, one of our programs as well, which provides intervention for children birth to age 3 with developmental delays. They're talking to families as well. We've partnered with the Rural Health Association, the Indiana Medical Association, and the Affiliated Service Providers of Indiana. And then last but definitely not least, our advertising campaign statewide continues as strong as day one. We are in every county in Indiana in multiple languages, on the radio, on TV, and social media. And the goal from all of this is, of course, to communicate directly to Medicaid members, but also to provide that layering and the reminders, right? Rather than just the packet coming and sitting on the kitchen counter, but then you get the reminder on the radio. Or maybe your friend or loved one saw a message and knows that you're on Medicaid and mentions to you, hey, have you done this? Or you get the reminder from your trusted provider or a community partner. And then in addition to that, there's just the direct messaging that we've done to the Medicaid members. For those who we know may no longer be eligible, we have contacted them directly with a postcard, their initial letter, sometimes referred to as a warning letter, their redetermination packet, a series of text messages, a phone call, and an email. That is in addition to any outreach coming from the managed care entities or hospitals. Before the redetermination process began, we had sent 700,000 postcards to people who did not qualify for auto renewal. And again, Nanis mentioned this, we're really focusing on consistent messaging and keeping it simple. Update your address, watch for the communication and respond. But then we are tweaking and adding in messaging as needed, such as the messaging regarding kiddos. We're producing new outreach materials that we will make available statewide, outlining steps now people can take if they find that they've lost coverage. We are finalizing that. It includes QR codes, so someone can do it right then, get right into the systems and do what they need to do. Are there any questions?
Michelle, one question in the chat. Could you repeat what you mentioned about the providers having a video? Did you talk about?
Well, we have several videos on our website that can be used. But other providers have shared with us how they are showing videos and then sitting alongside their clients to make sure that they have what they need to walk through this process, making laptops and such available.
Thank you. Senator Bro?
Michelle, thank you very much for that very strong, clear, I could hear you very easily presentation. I just, you're out, all the efforts sound commendable, but is there the ability to just get in the car and go out? Is that something that is just not done, or is there some reason why it can't be done? And is there any benefit to just dispatching a group of people by region and just saying, hey, go to these homes that of people who you've tried to reach, been unsuccessful to reach, and let's just see if we can get them?
Well, I understand what you're saying. I think to that, we have really relied on our community partners who are the trusted folks on the ground in that community to do that. And that's why we are in really constant communication with them, so they have the information that they need. I know a lot of them have been really interested in the per county breakdown, so they can look at that kind of data and do that work.
Okay.
Representative Fleming?
Thank you very much. Do you have any idea if there are, now that we extended the postpartum Medicaid coverage for a year, if there are women in the postpartum period who are losing their Medicaid at 3, 6, 9 months?
The way that we design that in the system, they are not due for renewals until the 12-month postpartum period ends. So they should not be pulled into this process. And just one thing, sorry, I just want to get in the chat because Elizabeth keeps asking, don't forget my question. We haven't. So the breakdown of the 7% of those who are over age 65, we do not have data on how many of those may have been nursing facility or assisted facility waiver residents.
Do you have a breakdown on the demographics of the disenrollments?
That's what I showed on the one slide that we have it by program. So HIP, Who's Your Health Wise, fee for service. We have it by age and we have it by race and ethnicity.
You do have, okay, I missed that, I'm sorry.
And we're happy to share that link to that part of the dashboard. Nanis demonstrated how to navigate that, but we'll make sure that that's reflected in the minutes as well. So that you can go and view that. Representative Clear.
Thank you. So we are tracking disproportionality in the procedural disenrollments.
Yes.
Okay. And I couldn't see the slide. Can you speak to that just briefly in terms of
yes, I can actually bring it back up in just a minute and I'll get back there. So this is the one that talks.
Nanis, I'm sorry, could we zoom in just a little bit?
If I can figure it out right there.
Perfect.
So this is the slide, and I apologize. It's actually a PDF, so I can't do all the things I'd like to on it, but where we track program. So HIP, Who's Your Health Wise, traditional Medicaid, which would be our fee for service population, or Who's Your Care Connect. And then we also track by age group under 19 to 64, which is mainly going to be our HIP population, and then 65 plus. And then we have it by ethnicity and also by race.
So how would you characterize the disproportionality in that population, the
We've seen a
procedural
lit-
disenrollment?
Yeah, we've seen a little variation across the months. Looking at July itself, sorry, I'm going to have to go back down a tick. Looking at July itself, there was a little bit of difference here, but when we combine across the months, we have not seen anything that looks like an anomaly to this point, but it is definitely something we will continue tracking.
Okay, thank you. One other question I want to make sure we don't lose track of. We've talked before, including a few minutes ago, about that the retroactivity not being available with HIP 2.0, and there have been conflicting opinions about whether that is statutory. So can you speak to that anymore this month or at this meeting? I think we talked about it at the last
Yes.
regular meeting.
From what we have seen and analyzed with our Office of General Counsel, it is in the Indiana Code. And so it's not something that we would be able to just waive.
So your general counsel has issued an opinion to that effect?
I don't know if I would say that.
I wouldn't necessarily say it's a formal opinion, but they have been consulted and confirmed that decision.
Yeah, I know there are other attorneys that have been consulted by stakeholder organizations that disagree with that interpretation and think that there may be some flexibility there, but you're saying there's no flexibility based on what your general counsel has said.
I think we'd be happy to have a conversation if there's, a disagreement as to the interpretation. I'm sure that Jessica Keys, our general counsel, myself would be happy to engage with anyone. So feel free to catch up afterwards.
I think that provision has always been problematic, but now it's proving to be especially problematic in the context of these disenrollments. So I'd like to see it revisited from an administrative standpoint in conversation with stakeholder organizations that believe there may be some flexibility. And then depending on the outcome of those conversations, obviously it could be addressed legislatively if need be. But that, that codification of HIP 2.0 has tied our hands a lot. And some would say that's a good thing, but I don't want to speak for FSSA, but I think it has been problematic at times since that law was passed in, I believe, 2016. So I would just appreciate it if you take another look at it with the stakeholders.
We'd be happy to do that. Thank you. Representative Shackelford.
Thank you. I'm kind of surprised by the HIP numbers. Doing redetermination calls outreach, I did it for 7 years for Medicaid. So it's kind of surprising to see HIP members, mainly adults, not responding to your phone calls and emails. 2 quick questions. Do you include text? Because I think I did write down that you do postcards, phone, and email. So are you texting the adults? And what does that return rate look like? Like, I know they change their numbers quite often. You have a lot of disconnects. So I'm interested to see how does that affect? What does that return rate look like? And then 2, since Indiana is different in how we expanded our Medicaid to include HIP and those adults, is there any HHS guidelines or requirements specifically on how do we outreach for redetermination for the HIP population? And is there any leeway since our numbers are so large given from HHS? And then what are other states doing? Because I know we're very unique in how we did that Medicaid expansion, but I'm wondering, is there any leeway that we can look at for our HIP population?
Go ahead. So I did bring up, this is a slide, which is the cumulative of all of the outreach we've done. And again, this doesn't count the significant outreach that our managed care entities are doing. So this is something Indiana has never done, text messages. So we have sent text messages. We send them to everyone who gets the mailer. It's a mailer type where they have to return it for us to be able to know if they can continue their coverage. So we have been texting those, and those represent, if we have, 3 or 4 members in one family that's due, we only text one time. So the actual number would be higher than that number. DFR has also been doing outbound calls and emails, which we've never done before. And we know that some of these methods are ones that are, especially our HIP age population, would be more likely to respond to than something in the mail. One thing to note for the HIP population is that we kind of expected this would be the largest group of disenrollments because it could include people who lost their job during the pandemic, but then got it back, and now they may have other coverage. And so that it was one thing we kind of expected to see. But Michelle, I don't know if you had anything you want to add.
We too were interested in looking at those texts, like the receive rates and the bounce back. The text directs folks to the website. So there is no, it's not like a text chat feature. But in the first few months, I know that the rate of receipt was, I believe, over 85%. So we were pleasantly surprised with the number of texts being delivered, but I can definitely look at what that's been every month, and we can share that with you.
Thank you.
And Nanis, do you maybe want to speak to just, I don't believe there's specific redetermination differences between the expansion population and the non-expansion population for HIP as far as CMS guidance or HHS guidance. Is that correct?
That's correct. The requirements are the same for all populations.
Okay. All right. Thank you.
Okay. Thank you. Thanks for the information, Nanis and Michelle. That was very helpful. So, I mean, I think we are certainly not stopping our efforts in outreach. We're, as Michelle said, completely committed and putting sort of the pedal to the metal on this, and we'll continue for the remaining months of the renewal processes. But we are pleased in seeing those renewals increasing, our number of ex parte renewals, where individuals don't have to return the same information, increasing, and our procedural disenrollments going down month over month, which I think does indicate that these very detailed and constant communication efforts are resonating and making a difference. Senator Bro?
Yeah. Has there ever been any thought given to providing some kind of an incentive to the boots on the ground, the providers, the MCEs, those folks who are in direct contact with membership, to encourage them to reach out and do everything they can to get as many of their folks re-enrolled? Is there any kind of an incentive program or thought given to that?
So I will start first, and then maybe Cora or Allison can weigh in. We do not have an incentive program, but we are in the lucky circumstance that all of our goals and desires are aligned, because as much as we want people to keep their coverage, their managed care entity definitely wants them to keep their coverage, and the providers do also. So we've had a great partnership with them because we all want to see this happen, and we want to reduce the number of procedural disenrollments as much as possible. So I don't know if anything that anyone else.
No, that's a
and
great
and you're
answer.
probably right. That's probably accurate. So that there's a self-determination or self-motivation to get this done by the providers of the MCs. Okay.
Yes.
Thank you.
Do we have anyone signed in for public comment? We do not have anyone signed in for public comment. Great. Okay. Well, we did not get to our rate matrix update, so we will definitely put that on our November agenda. Who was teed up, ready to go. So we will put that first up next time. But definitely appreciate the active engagement of the committee, and happy to have had the chance to discuss in such great detail those two topics that we were able to cover. So our next meeting is Wednesday, November 29th, as we mentioned, at 10 a.m. Anything else, Terry, before we adjourn?
Am I allowed to ask one quick question?
Of course.
Okay. I was just curious about if what is being done, or what has, if anything, has started in terms of the state doing the analysis on Medicaid reimbursement state by state that was required in this last legislative session.
Yeah, we have we've had some brainstorming meetings to look at different sources, so we're starting to work on that. We'd be happy to give you an update offline in terms of what we're looking at.
Yep, absolutely. And you're referring to HEA 1004 and the Medicaid costs. Yep, we have been having those discussions. Happy to invite or update you on those activities.
Great. So thank you.
Great. All right. Nothing else. I think we are adjourned. Thank you.